Hello, everyone, and welcome to this Monday's NAMI at Home, brought to you by NAMI Tennessee. My name is Gabe Howard, and I am super excited to be here to discuss suicide prevention, an important topic and one that we have wanted to cover for a while. Now, before we bring on not one, two incredible guests, I want to remind everybody to please sign up for NAMI Tennessee's email list. It's how you can find out about really cool things that we're doing, like, for example, the NAMI at Home series and the Facebook Lives that happen every Monday. I promise we only send about one email a week, and it's curated content, and it's really helped people through the pandemic. Lots of very cool stuff. All right, that's enough about that. You know to go to namitn.org, sign up for the email list. Let's bring on our guests. Hello, welcome.
Thank you.
All right, well, Elaine, in the spirit of ladies first, would you mind introducing yourself first and just tell our viewers who you are, your expertise, and a little something about you?
Sure. So thank you, Gabe. My name is Elaine deMello. I am the Director of Suicide Prevention Services at NAMI New Hampshire. I've been there for 21 years. Prior to that time, I worked in community mental health. Many of those years, both at NAMI and in community mental health, I worked with Ken Norton, my colleague here. So really excited to join him again. And I guess if you could just say that I've been in the mental health field for 40 years or so, it's truly a passion of mine. And I'm grateful to be here and grateful to be with NAMI New Hampshire and connecting with NAMI Tennessee.
Well, we are very grateful to have you here as well. Thank you so much, Elaine. Ken, would you mind introducing yourself? Pretty much the exact same rules that Elaine had.
Sure. Ken Norton, and I'm the Executive Director of NAMI New Hampshire, and I attended my first NAMI group in 1982 when I started to work in community mental health, and that was the WAMI group, the Winnipesaukee Alliance for the Mentally Ill. And I've been involved with NAMI since then in one way or another, as a volunteer or professionally. And Elaine recruited me to NAMI New Hampshire in 2003 to develop our Connect Suicide Prevention Program, and we'll be saying a little bit more about that. So I've been employed there since 2003, and I've been the executive director since 2011.
Ken, welcome to the show. Elaine, welcome to the show. We're very excited to have both of you. It's not often that we get two guests, so I'm going to try to juggle you both as best that I can as questions come up. Speaking of questions, remember, you can ask questions to our guests. Just plop them right in the comments. It is moderated by me, so don't panic. As soon as you type it, it doesn't just show up on the screen. We wait until a natural pause. So you can put them in there anytime while we're talking, and we will answer as many as we can. All right, the first question that we have, Ken or Elaine, there's suicide prevention everybody thinks that they understand suicide because they've heard of it, but in reality, there's a lot of myths, there's a lot of confusion. And I know that it's difficult to say, can you sum up suicide prevention quickly, but what exactly are we going to be talking about for the next hour so that our viewers can kind of get their heads wrapped around what we're going to be learning and moving forward with? It's probably an Elaine question.
Well, I'll start. Ken can certainly pitch in. You got two of us, but it's really it's a tag team. So suicide prevention is something that is a public health issue. And by that, we mean it really belongs to everyone, and there's something that everybody can do. So if you're worried about somebody, don't wait or hesitate to do the right thing. And if you haven't been trained in suicide prevention, you can still take a very caring and compassionate approach, which means that just showing somebody that you care about them and that you're worried about them can start to open the door to them getting some help. And we know that help seeking is a really important part of getting well. But for many of us dealing with mental health issues or suicide risk, getting help, there can also be a lot of stigma to that. So as people in the community, as caring family members, as people that work in a profession, whatever role we play, we can start to open the door for other people to get help and let them know there's nothing to be ashamed of. If they're feeling distressed, if they're feeling like they want to die, that we or someone that will connect them with is there to help them. And we're going to start that conversation and see it through and be there to make sure that they can get the help they need and be okay and get well. And the other part of that is people can and do recover from crisis and can move on and lead very productive and healthy lives.
Now, this question is either for Ken or Elaine, whomever wants to tackle it. But one of the things you said is we need to have conversations surrounding suicide. And a pervasive myth that's out there is that talking about suicide causes suicide. Can one of you address that for our audience?
Sure, I'll go next, and I'll just say that that is a myth, that talking about suicide is the best way to prevent it. And following up on what Elaine said, that if you're concerned about somebody, that one of the best things you can do is to talk to them directly and to ask them, are you having thoughts about harming yourself, or are you having thoughts about suicide? And certainly that goes for schools, it goes for therapists and clinicians, it goes for family members. It's really across the board in terms of talking about suicide. And I'd just like to jump back for your first question, to add to what Elaine said, that that when we are talking about suicide prevention, that we're often talking about three different things. We talked about the importance of it being a public health issue, but it's about prevention, it's about intervention, and it's about what we call postvention. And prevention being how can we help support somebody that has maybe having thoughts about suicide, and I will identify as somebody that's had thoughts about suicide my entire adult life. I've never acted on them, but they have been pretty intrusive sometimes. And then intervention is intervening with somebody that might be at risk. And then another part of suicide prevention that's very important and often overlooked is how do we respond to individuals and communities to when there has been a suicide death, to help them recover and to promote healing and reduce risk after recovery. And part of that is to take a community-based approach to suicide prevention. And I'm going to tag with Elaine and let her talk a little bit about what that means and how the Connect program takes a community-based approach and the socio-ecological model and those things. So Elaine, your turn.
Thanks, Ken. So Ken and I had the privilege of working together to develop the Connect program almost 20 years ago. And we knew, and based on all the evidence and the national research, which was pretty limited at the time, that taking a comprehensive approach was really key, because we know that sometimes people at risk for suicide touch the mental health system, but more often before they even get there, they're in contact with their family members, their friends, maybe a police officer. If it's a student, it might be somebody in a school. It could be any number of people at any point that can come into contact with someone who's at risk for suicide. And so every one of those people needs to know, first of all, that they can do something about it. They can ask the question, they can reach out, they can start to engage with the person, and they can be part of what gets them to help. And so we created the Connect program considering all of those sectors of the community, thinking about who could come into contact with someone at risk for suicide. Everyone, right? Faith leaders, schools, mental health, healthcare providers, first responders, emergency providers, you name it, social service providers, correctional officers, any number of people. So we created the program so that it would be all encompassing and would give all of these people some general, consistent information about suicide prevention that was based on evidence-based practices. And then we built protocols in so that each one of them would also know what they would do if they encountered somebody based on their role, and how they can ensure that that person that they encountered got the right response from them, and then also that they would know who to refer that person to so that they could make sure that that person got help in an expedient, but also in a caring kind of way. So we created really a system, not just a program, not just a training, but a system of protocols, that includes consultation, training, and a way for a community to come together, interact with each other in a way that creates pretty much a seamless safety net when we can implement it in a thorough kind of a way. And when we did this across communities, starting in New Hampshire and then in other places around the country, what we found is as they worked their way through this comprehensive approach, they could actually, they found that the referrals would happen much more readily, the stigma was reduced, people were getting help quicker, people who were making the referrals were better equipped to know what to do and how to proceed. The people who were getting the help felt better about the help that they were getting. And ultimately, we feel like we were able to prevent adverse outcomes and hopefully save lives.
It sounds, and please correct me if I'm wrong, but it sounds like first aid, except for suicide prevention. I mean, it seems like, I know, like for physical health, if I hurt myself, my family knows what to do. If I cut myself, they don't just say, "Oh, get over it," or "buck up," or "cheer up," or whatever. They put pressure on it, right? And then they call 911 and get me to a hospital. Is this like first aid for suicide prevention, or am I just completely off base?
I think that's a way to look at it. I mean, certainly people might be familiar with mental health first aid, which is a national training that's available out there for mental health. But I think that, to the extent of what I think you're implying and what Elaine said, we want everybody to be able to recognize the warning signs for suicide. If you ask the average person on the street, what the warning signs are for a heart attack, they can, probably tell you. And in order to address suicide as a public health issue, we need to be better versed as a society, as individuals, workplaces, communities, families, to recognize when somebody is potentially suicidal. And I see that one of those questions is, are there signs? Yes. I mean, one of the signs is somebody talking about suicide or talking about death, or making comments, even jokingly, about that. Well, maybe everybody'd be better off if I were dead, or hopelessness, a lack of looking towards the future, impulse control issues, being very impulsive, and then signs of depression like sleeping too much, eating too much. Those kinds of things can all be warning signs for suicide.
And I think that's a great analogy. If I could just tag on, because Ken and I tag team. One big difference between first aid with a physical condition or a medical condition is we don't hesitate to step in when we see that somebody looks like they're having signs of a heart attack or they've had some injury to them, right? We step in and we get them the help that we need, or we make sure we get the right help. The problem with mental health issues and suicide risk is we don't always know what we're looking at. And even if we do, we're afraid to do the wrong thing, or because of stigma, we're afraid to get involved, or for a variety of reasons, we think it's none of our business. And that's what we have. That's the part we have to change. And that's the part that is different, is we need to give people the comfort level and also the knowledge that, yes, you can step in just as if it were a medical emergency, and at least show that person that you care, stay with them, keep your eyes on them, and make sure you get them emergency help if it's a very high risk situation.
That was the second part of the question that Ken answered, are there signs? The first part was, do you just ask somebody if they are suicidal? Just walk up and say, "Hey, are you suicidal?" What are your thoughts on that?
Well, I mean, you're probably not asking a stranger that. I mean, but if it's somebody that you have a relationship with, you probably want to ask some preceding questions, like, or maybe observations like, "Hey, I'm kind of concerned about you. You don't seem like yourself lately. Is something up?" And, you might want to ask a few of those questions first, but then, yeah, I mean, you ask them outright if they're suicidal. It'd be much better to ask them and to have them say no than to not ask them and then to find out later that they had made a suicide attempt or taken their life. And so we do want people to be able to have that conversation and to feel comfortable about having that conversation with somebody.
And we also know of examples where that's a good way to approach it if you know the person. But we also know of examples of people who've been pacing a bridge, and somebody comes along and says, "Are you okay?" And it's a total stranger. And that person feels relief, like, wow, somebody showed enough interest that they cared. And I'm going to tell them that, yeah, I'm thinking about jumping off of this bridge, and maybe I'll go get help instead. So even an intervention with a stranger can make a difference. If any of us have ever had those days where, you were in a supermarket and you just saw a parent who looked like they were just ready to have a meltdown with their kids, and you just walk by and you smile at them and say, "How you doing?" That can really just be enough to uplift them. Well, for somebody who's suicidal, it could be that connection, even from a stranger, that makes a difference in that moment.
Thank you so much. We have another question from the audience. Was suicide going up before COVID? And if so, why?
So, that's kind of a tough question, but yes, the answer is that nationally suicide rates have been going up prior to COVID. And although the last year of data, which was 2019 or indicated that rates had gone down a little bit nationally. There are a number of factors that contribute to suicide rates, and I can certainly go into them in a little bit more detail, but I'll just say, quickly, and then we can, Elaine can chip in, or we can talk about them, that I get this question a lot from the media, about suicide rates and the suicide going up, and I used to give these long-winded, complex answers because it is a very complex question. But now I give a more simple question, which is to say that the rates have been going up because as a society, as a country, as our community, as our state, we have done very little to prevent suicide and to address it. And we are starting to do more. We're probably going to talk about the 3-digit 988 legislation to create a 3-digit National Suicide Prevention Hotline. But the short answer to that question is, unlike other health initiatives, we spend very little money on research relative to suicide, and we spend very little money in terms of trying to address suicide as the public health issue that it is.
When you say address it like the public health issue that it is, I think of how we're addressing COVID, which is like all hands on deck. Everybody's learning about it. It's just everywhere. When you say address it like a public health crisis, does it involve each and every single person on the planet?
Well, not exactly, but I think to your point, and this is something that I've made, we in New Hampshire, and I just saw an article about, a national article this morning that, other states are experiencing significant increases in emergency department boarding. I don't know if that's an issue in Tennessee where, there are more people seeking inpatient care than there are beds available for them. And so the analogy I give is that we can stand up surge centers for inpatient units for COVID and mass vaccination sites as we should, but as we're seeing these increased numbers of people who are seeking help and who may be suicidal, some of them, we could be unable to set up the same type of supports for them and deal with it as a public health crisis in the same way.
So it really is like an all hands on deck thing. I think that people, I think that sometimes people believe that suicide is just something that severely mentally ill people have to worry about, or something that families who have challenges or issues have to worry about. This will never happen to me because fill in the blank, or where we live, I have a nice house, how much money we make, we went to college, we're not divorced, etc. But it really does touch and impact everyone, and therefore needs a solution that addresses everybody from the severe and persistent mental illness all the way down to whomever. It doesn't have a look, right? Is that my understanding? Am I understanding that correctly?
That's correct, Gabe. It can affect anybody, and it really doesn't matter what your resources are necessarily. That's an important thing, but it's not going to prevent a suicide if you're really struggling. We look at people like Robin Williams and other celebrities who appeared to have everything going for them and yet still lost their lives to suicide. So I think, as Ken said, we really need to stand up the resources that are needed to address this. The good news is that actually the latest report that I read is through August 2020. Nationally, the suicide rates have not gone up relative to COVID, at least not yet. And I think even though we didn't stand up crisis centers and things like that during COVID like we did vaccination centers, we did come out with things like the stimulus package and other things to help people keep their security. so that they could, at least financial security, which does help stabilize some parts of our lives when there's a major disaster going on, like a pandemic. And that can help cushion people a little bit. It's not going to prevent suicide ultimately, but it does help reduce some of those risk factors that could be associated with suicide.
Thank you so much. We have another question from the audience. When training on suicide prevention?
Well, you know, from the shameless commerce division of NAMI New Hampshire, we would certainly say that, you know, that our Connect Suicide Prevention Program is a national program. It was a best practice program, and that's in prevention, intervention, as well as responding to a suicide death. As we explained before, it does take a community-based approach, and you can find information about that at the connectprogram.org. Or you can also link there from the NAMI New Hampshire website. And Elaine is the lead for that program, and she can be a personal contact for that as well. I mean, another place to look is the Suicide Prevention Resource Center, which is www.sprc.org, and that has listings of other programs nationally that are available. And those would be two potential resources to look for training.
Sometimes what people do is they'll contact their local coalition, or if they're in a school setting or a hospital setting, they'll speak to their administrator there. And then you have a state suicide prevention coordinator who could probably direct you to training. And if you're interested in the Connect program, you can certainly contact me, and I can talk with whomever about bringing the Connect program to your site.
Let's stick with the Connect program for a moment. What can I expect? I call you Elaine and I'm like, all right, I'm ready. I want to bring it to my site. What does it look like? What does it feel like? How long does it take? Can you expound on that a little bit?
That's great. Sure. We have a lot of different options because we're not like a plug and play kind of a program, you know, just take it off the shelf, plug it in, check it off, and then you move on to something else. We really do try to take a very comprehensive systemic approach. So I would say to you, so Gabe, tell me about your setting. Are you in a coalition, a community? Are you in an organization? Are you in a school? And who are the people that want to be part of this? And then I would offer you and discuss with you lots of options. You could be in a tribe. You could be in a military setting. We've trained all over the place in all kinds of settings. I'd get to know your setting. We'd discuss what kind of training you wanted, who were some of the audience members, and then we'd work with you on designing that training depending on who you're going to get trained. We could just do a half-day training, a one-day training, a shorter training, or we can work with you to train the trainers, which means you then go forward with a certain number of people that can then carry the program forward and train it. We could do a strategic planning session with you. So we have a lot of different ways that you could implement the Connect program, some of them just being very brief, one day or less, some of them being more strategic and systemic around planning and might take a few days for us to work with you to implement. And then post-COVID, we would have come to your site. During COVID, we would do it virtually with you.
And I just want to let folks, a lot of our audience is in Tennessee, so I want to point everybody to the website that's currently, I guess it's that way right now. I'm doing a poor job of pointing at it. It's at tspn.org is resources specifically to Tennessee. So there's lots of resources out there. And I also think it's a good time, of course, to bring up the National Suicide Prevention Lifeline. Now, that's not a place to get training. That's a place to get help and or support. But it's important to know. And that number is also on the screen right now. Now, we've talked about training and we've talked about what people should do if they feel that their friends and loved ones may be experiencing suicidal thoughts or maybe in danger. But let's shift the focus. And what if I realize it? What if I'm sitting there and I'm thinking, okay, something's not right here. What do I do?
Are you referring to yourself, Gabe? And I'll let
just the individual. If an individual is realizing that something is not right, how should they go about, like, not how should they, but what are some options that they can do to seek help on their own for the feelings that they're having and things of that nature?
Okay.
So, I think the first thing is, you have the National Suicide Prevention Lifeline number there. That can be for the individual. but it could also be for a family member or a friend who's worried about somebody. And so I think, you know, the starting point is to recognize that it's okay not to be okay. I mean, that, but, you know, what you do once you recognize that is really important. And, you know, lots of different people. And as Elaine said before, it doesn't matter what walk of life you're from, or, you know, your socioeconomic position, law enforcement, military, you know, business people, whoever, you know, all have thoughts of suicide at some point, right? And, you know, and maybe at risk for suicide. The other opportunity is to call the crisis text line, which is, believe you type home to 741-741, and that can be a good resource that, you know, that someone has. And then, you know, I think thinking about who in your life you can reach out to. I mean, and I think it's a good question that you know, we use this in training sometimes to say to people, and especially younger people, who could you call at 3 o'clock in the morning if you're in trouble, and who would answer and be a support for you, and just, you know, recognize who that is. I think one of the challenges that we know about suicide from people who have made serious suicide attempts is that, you know, they lose their perspective at some point, and they describe this kind of tunnel vision that they have where, you know, they're not thinking clearly and they're not very focused about, they're just sort of looking in this very dark place, and it becomes very reinforcing. So being able to reach out to somebody and to get help can be really helpful, somebody that you trust, and to say, you know, that I'm not doing real well right now and I need some help and support.
Thank you so much. Now, oh, I'm sorry, Elaine, did you have something to
Well,
add?
I was just going to say,
Please.
we'd be remiss if we didn't say, and of course, there's always NAMI, right? Well, it might not be a 24/7 emergency line. It might be that place that you can get some peer support, you can get some classes, support groups, things like that if you're struggling with a mental health condition.
I could not agree more. Thank you so much. All right, we have another question from the audience, which is sort of shifting gears again a little bit. This person asks, what about threats that are manipulative in nature? And the example that they give is, if you leave me, I'll, or if I don't get my way, I'll. How do you handle those?
Well, you know, first a little bit about language, because that's a that's a great question, and on multiple levels. And, you know, one of the things that we talk about with language, and we can say more about this in a minute, but, you know, we have tended to, for years, classify anybody talking about suicide as a threat. But as this questioner writes, a threat is like is worded here: if you leave me, I'll kill myself. And so I think that, you know, that the first thing is to, you know, to say to that person, and to say very clearly that, you know, this is not something to joke about, and to, you know, really ask them whether they are suicidal, and to consider whether they need help, and are they willing to get, you know, help for that. You know, oftentimes when those examples are used, or those words are used, it could be in a potential domestic violence situation, and the person who that statement is being directed towards may be at risk themselves for, you know, for violence if they're thinking about leaving that person. So, you know, it would be remiss to also sort of not say that that, you know, is the person on the receiving end of that feeling like, you know, that they are being threatened, and that their safety might be in jeopardy as well. So, I mean, that's, you know, that's kind of a complex situation. But I guess I would also say that, you know, most situations when people disclose that they're thinking about suicide, it's not manipulative. And what we just saw nationally or internationally was Meghan Markle, who's married to Prince Harry,
Prince
or
Harry.
sorry, I have trouble with, you know, with the lawyers, you know, celebrities. But, you know, she disclosed on national TV that, you know, she had felt so distraught at one point and so isolated that she was thinking about harming herself, to which point, these other media personalities and pundits immediately rip her apart and say, she didn't really feel that. She's just saying that because she's looking to get sympathy from people. Well, that's just a bunch of bull. And for somebody to say that about themselves, more often than not, is a very serious statement. And so you want to take that seriously, and you want to convey to the person that's making that statement that you take it seriously.
Thank you so much. It sort of reminds me a little bit of ways that we diminish things. You're not you're not actually sick. You're faking. You weren't actually hurt. You're exaggerating. It wasn't that big of a deal. These are all words that tend to minimize things. And while I'm certain that it does happen, we've all been around, maybe people that don't understand what those words mean. And I sometimes think of teenagers. I think of the outburst that adolescents yell. I think you're right, Ken. They don't realize what they're yelling. They don't realize the impact of those words, and there is a learning opportunity there. And I'm kind of glad that you addressed it that way, because so often it's addressed as, well, those people are bad, or et cetera. And there is an educational component as well, because immaturity does play a role in saying less than satisfactory things sometimes.
I think that is a complex issue, and that was a great response from Ken. And I think sort of one of the baseline responses that Ken offered was take it seriously and let the person know that you do take it seriously. The other thing I would suggest is, we don't want to get into a cry wolf situation and say, well, they say this all the time and they're not really going to follow through. We don't know that. But we also, if we're not the clinician that's going to work with this person, we don't have to make that decision about whether it's serious or not. Let a mental health professional make that determination, and let that person work with this individual if they need, if they're making those kinds of remarks. And do take care of yourself. If you don't feel safe, or you feel like a person is potentially putting you at risk, pay attention to that and take the steps you need to without harming them, obviously, or dismissing them. Take good care of yourself in the process and your mental health.
One of the things that I was thinking about is, when we're talking about whether or not somebody is, crying wolf or being manipulative, this isn't simple, right? It's somebody who says that they might wish to retract it and say, oh, I was just kidding, when it was anything but, right? It's an uncomfortable feeling to say out loud. I imagine it's not clean, where somebody says, I'm thinking about hurting myself, and then Ken responds, okay, I will get you help, and then I get help, right? There might be many, many moments of asking for help, crying for help, retracting it. This isn't something as simple as a role play that we can do on this show. It's very complicated. So somebody might not be being manipulative at all. It just might appear that way. Is that correct? Do people say these things more than once and are very serious? It just comes out that it just looks off?
Yeah, so there's a lot in that question.
Yeah.
Let me try to unpack it a little bit, which is that I first want to pick up about your comment about that these things aren't clean, and that's right. And we're human beings, and we're messy. It's and feelings and relationships and and whatnot are complicated. But people shouldn't hesitate to consider to get somebody help, or or to respond to a situation, because they're afraid that they're just not going to get it right. And they should, while obviously you want to do your best to try to get it right, don't let the perfect get in the way of the good, which is this, the expression goes that, this person's hurting, and you want to help them, and that's what you need to get, coming across. So, I think to, some of the points that, Elaine's talked about before, and we've talked about, we don't hesitate to step in and get medical care for somebody if we see that they're injured or they need first aid. But, if somebody is crying or clearly in emotional distress, we hesitate because we think that that's private or whatnot. So we need to get over that, that hesitation. And I think, part of that is, is not being afraid to not exactly say it perfectly or say the right thing. And hopefully it's just a conversation that, that you can have with somebody in terms of seeing where things go from there and what, furthering that conversation. I mean, the other thing is that, you're not assessing that seriousness of the risk. I mean, I guess, everybody is on some level, but really, you're trying to get them connected with help. So, maybe you're going to follow up by calling the Lifeline, the Suicide Prevention Hotline, 800-273-8255, or the crisis text line, 741-741, to get, check things out for yourself if they won't do it for themselves. So, there's that, part of it as well, in terms of making sure that, part of the goal is to not determine whether they're serious or whether it's manipulative or whatever, but to get assistance from somebody, professionally, who can help you determine that. And then, the other thing that came to mind in your question was that, that comes up a lot, and particularly with teens, is, but not exclusive to teens, was, well, if you tell anybody this, I'll never be your friend again. Well, if they take their life, they're never going to be your friend again either, and you're going to be living with that for the rest of your life. So, so it's best to, to go ahead and make sure you get them help, and, tell them you're going to get them help, that you're not going to keep this a secret.
Thank you so much, Ken. Elaine, did you have something to add to that?
Yeah, no, I think that's a great response. And I guess, once again, if I could summarize it, the answer is never worry alone. Even if it's not for you, if it's for somebody else, just have a series of those 24/7 numbers readily available in your phone, or wherever, so that you can make the call on behalf of somebody else and not feel like you're out on a limb with something that might be really serious. And you can call on behalf of somebody else. It doesn't have to be because you're the one in crisis. Maybe it's for somebody else who's in crisis.
Thank you so much. I think that it's interesting in mental health in general. In physical health, we suspect that we have a problem and we get it checked out. We think we have the flu. We think we have pneumonia. We think we have pink eye. We think we have strep throat, and we go. And for some reason in suicide prevention and in mental health, like, well, we have to be 100% positive that there's an issue before we'll seek help. We're not allowed to be 100% positive. We can't diagnose anybody. We should never be 100% positive. That's not our role. Our role is suspicion. Is that a fair way to put it? I think one of you said, let's say that you take them to the hospital or call 911 or have them, you talk to them and you're wrong. Well, I mean, that's not the worst thing in the world. That's just an apology or a discussion. It's way worse to be wrong on the other side. And that spoke to me. Thank you. Thank you.
That's a great analogy. I'm thinking if one of my friends was short of breath and having a really hard time, and I were to say, well, let's go get that checked out, and they were like, no, I'll be fine. I'll be fine. I think I'd probably put more pressure on them and say, no, I'm worried about you. Let's make sure make sure you're okay. Let's be safe and not sorry. Why not do the same thing with mental health, right? Except that we don't sometimes.
And I love how you characterize that, Gabe, that we, when we're thinking about a medical issue, we go and get help. I mean, just, I'm worried that whatever. But with mental health issues, we tend to wait and wait and wait and put it off and put it off. And so, part of that issue is not waiting and to, go ahead and seek support and help.
And just like medical issues, early intervention with mental health issues can prevent something from getting a whole lot worse, right?
Absolutely.
So why wait? And as Ken said earlier, so if you're wrong, you're wrong, okay, turns out you're okay. That's great,
Yeah, it's fascinating, right? That's great news. Nothing was wrong. I mean, again, in physical health, we would go out to dinner and celebrate that we wasted our time at the doctor's office. But I think there's a general misunderstanding of how mental health works and how we're supposed to respond to it. And I think that it's an important message to get out there that, look, it's not your job to know. It's your job to suspect, and it's your job to intervene in the way that is best, right? And in this case, it could having somebody see a doctor, calling the support line, texting home, texting the crisis text line. It's just so much better than doing nothing. And I think that's your message as well, right? One of you, I think it was Ken, that said, "Don't let perfection get in the way of progress." Progress is vital. Perfection doesn't exist.
Mm-hmm.
Yeah, and that was also a great example about the celebrate piece. I mean, I would just say that, people wear as a badge of honor that they're a cancer survivor, or, that they've had a heart attack and, a quadruple bypass, but it's still, there's still a lot of negative attitudes. I mean, there are hundreds and hundreds of thousands of people in the United States who have attempted suicide at some point in their life, but they never talk about it. And perhaps it should be something that they celebrate, that it was a defining moment for them, and that they're still here, and that they're, doing well. And I think if we did get people to talk about that more, and there are programs like In Our Own Voice, and other, NAMI programs where we do hear people talking about that, then that would open up the door for, for other people as well, and to maybe talk about their own experience and provide hope and resilience to people in the future in terms of that maybe having, their own thoughts of suicide.
And I would add that if you're the one who's going to make the intervention, if you let care and compassion be your guide, you probably can't go wrong. I mean, because you're doing it because you really care about the person. And it even could be a stranger that you just notice is in distress. That care and compassion is going to be the first start of them feeling better about what's going on in their life and feeling like somebody cares.
Oh, thank you, Elaine and Ken, both so much. We've got another question for the audience. Is there a correlation between loss and stress and suicide?
Loss and stress and a whole other host of risk factors can certainly contribute to suicide risk. And loss can be, it can be a major loss, like someone important to you dies, or it could be a loss that other people might not notice, but you're very aware of, like you lose your job, or you have something happen that other people wouldn't think is significant. Like, for instance, teenagers, very often it's a relationship breakup. And the rest of us might look and say, well, you only dated that person for a while. There's plenty more fish in the sea, and you're young and you'll get over it. For that teenager in that moment, it might be a huge loss. So whenever we know that somebody's had a loss, we really want to see what that loss means to them and how important it might be. If someone loses a job, it might be their whole identity. It might not be just a matter of, I'll just find another job. For some people, that might be a huge loss. So yes, stress as well. And there are things we can do to cope with those losses and stressors, but we should recognize them as risk factors.
Thank you.
And I would just add that suicide loss particularly can lead to increased risk for suicide. When we know somebody or have been close to somebody that dies by suicide, that can increase risk for suicide, particularly among people who maybe have already been having thoughts of suicide. And we see that connection, which is sometimes referred to as suicide contagion, when there has been the suicide death of somebody famous. But it certainly can also be for somebody that is close to us as well.
Another question from the audience: have numbers risen for preteens or children under 10?
Boy, that's a tough question.
I know.
I'm going to let Ken answer, and part of the reason I hesitate is because I'm not sure that we count suicides under the age of 10 as a suicide, and so I think I don't know if that's state to state, whether those numbers get counted or not. Ken, I'm not sure if you know the answer to that.
Yeah, so I would concur. I mean, I believe that the Center for Disease Control, which officially counts suicide deaths, does not count suicide under the age of 10. I think, and even some medical examiners may not count it over the age of 10. They believe that, depending on the situation or, whatever, that person a young person didn't have the capacity to understand, the permanency of what they were doing. That's particularly for the under 10s, that's been an issue I think we have seen, an increase in the 10 to 14-year-old age group. But again, those numbers are so small that they may not have statistical significance, or it's hard to, sort of place a statistical significance on them.
When it comes to, I'm having trouble wording this question because it's such a scary topic, but I think maybe the crux of the question is suicide impacting younger people more today than it was 40 years ago, 30 years ago, 20 years? Are children having issues with mental illness and suicidality more so in 2021 than they were in 1980? Or has it been pretty steady across the board in the past few generations? Or do we just not know?
So I'm sure Ken will offer some insights on this as well. I think we may be doing a better job of identifying young people. So when we say we don't count suicides under the age of 10, it doesn't mean that young people aren't at risk for suicide. I think we should be really clear. And it goes back to that earlier discussion about take it seriously. If a 8-year-old says, I want to die, take it seriously. Don't just say, oh, he's just a kid, or she doesn't know what she's saying. Do take it seriously, because they are capable of self-injury that could lead to their own death, whether we count it as suicide or not. I think we are getting better at detecting and recognizing mental health problems and suicide risk in younger children. And I think with the whole exposure to social media and them having access to information and images and messages that they didn't before, I think that also potentially increases their exposure to things that could put them at risk.
Ken, did you have anything to add there?
Yeah, I hesitate. Statistics, it's hard to keep some of these things in the top of mind. I think that Elaine's point is really important, first and foremost, about, take any, regardless of age, take any potential risk seriously. I think that the trend had been for, over the last few generations, and I think that yes, from over the last few generations of the age on, we have seen that an upward trend in youth suicide. But I would really need to go back and look at that data, and I know that at some point during that time, we started to see suicide rates for young people trend downward as well. We do know that some of the federal programs, like the Garrett Lee Smith suicide prevention grants, which Tennessee was one of, as was New Hampshire, one of the first states to get them. That has demonstrated a reduction in youth suicide rates, and that's that's youth up to age 24. But that data has shown that it's really only during the time that those grants are in place that when that funding goes away and that infrastructure goes away, that rates tend to creep back upward again.
It's interesting, though. Basically, what you're saying is that we have solutions. We can prevent this. We can save lives. I believe you specifically said when we're doing something, the rates go down, and when we stop doing that, the rates go up. Is that it? I don't work for the government, but in my mind, why did we stop? That's proof of concept.
Well, these grants were, in their initial phases, they were 3-year grants, and they've now extended them to 5-year grants. But to some extent, it's a funding issue, and there isn't, there have been different categories of grants. So there's state grants, there's tribal grants, and there's college and university grants. But again, when we're addressing a significant public health issue, which involves changing culture essentially, and and how we think about things and how we act, and training and whatnot, it takes time, and to be effective over a period of time is really important. But we do know that there are certain things, to answer your question, that can reduce suicides, and that includes reducing access to lethal means. It can include screening, which is now something that didn't typically take place in primary care providers in emergency rooms, which is now happening much more universally. It can mean working with the media around responsible reporting and safe messaging. So, there are definitely things that we do know that can help reduce suicide deaths. And the hotline, I should say, as well. Yeah.
Ken, do you want to say something about 988 here too?
Sure. So, Congress and the president passed the National Suicide Prevention Act of 2020 in October of 2020. And that will create a 3-digit National Suicide Prevention Hotline number, 988, which will go into effect in July of 2022, and that's around the country. So again, the number right now will continue to be 800-273-8255, but in July of 2022, nationally, anybody that dials 988 will go into the suicide prevention hotline. I think by everyone's understanding and agreement that will no longer be a suicide prevention hotline. It's really going to morph into being a national mental health crisis line. And, and it's very exciting to think about that individuals and families will have an alternative to calling 911 when there's someone in their home that's not safe, or when there's a crisis, or to going to the emergency department. And hopefully, that would be responded to initially by some screening and assessment, and then perhaps by a mobile crisis team that would come to your home, that would include somebody who has professional training to assess, the mental health crisis, as well as being accompanied by a peer who is also trained, somebody who may who has a mental illness or who has previously attempted suicide or been hospitalized, who's able to get hope and talk to the person, about their coping strategies and their recovery process.
If a follow-up question to the 988, is it kind of like 911? Would I dial 988 if I just wanted to talk to somebody, or if I was feeling suicidal, or would I only dial 988 if there was a problem in my home, like if I was worried about my family member, or will it be both? Do we finally have one number that encompasses all?
Yeah, it's a great question, and I think originally, and I've been working on this, on the legislation piece for a couple of years. I am on the National Suicide Prevention Lifeline Steering Committee, although the committee itself wasn't able to be directly involved in the in the legislative effort, but a subgroup of folks was. Certainly it's something that there are warm lines in many states and areas. Many of them operated by peers that would be more of the, hey, this is a place that you can call if you need somebody to talk to. But if you're thinking about suicide, absolutely 988, or you're worried about a family member, or maybe somebody they're not suicidal per se, but they're in the middle of an extremely serious depressive episode, or maybe they're experiencing some mania or severe anxiety, or other symptoms of mental health conditions that you could call to get somebody assistance and to get them evaluated. So if you were thinking, wow, I'm really worried about my loved one or myself, I should go to the emergency room. Well, instead of going to the emergency room, you could call 988, have some type of assessment and screening done, and then hopefully have a mobile crisis team come to you to make that next step about what's needed and how to best support you and help you getting help.
And currently, the current method is you dial 911 and you kind of hope for the best. I'm not insulting 911 or police, that we're all doing the best that we can, but the current system is it's a little bit of a mixed bag, right? Sometimes you get the CIT or a mental health trained officer, sometimes you don't. Sometimes the dispatcher understands, sometimes they don't. Sometimes it gets written down wrong, and the call goes out completely different with what actually is happening in the home. So this is a huge step forward. That's how I see it.
We hope so.
Yeah.
We hope that it'll eliminate that that trauma and that drama of having to ride in an ambulance or a police car to an emergency department where you may or may not get help quickly, because we know emergency departments get backed up, and it can be a long wait before you get to see somebody. So we hope that it'll be a good alternative that keeps people in their communities and provides an effective but more localized response that can help stabilize a crisis and minimize any really extreme interventions that might not be necessary.
Yeah, I would add that, that short of the Affordable Care Act, which did away with pre-existing conditions and, allowed for health insurance coverage for young adults up to the age of 26 on their parents' plans, where major mental illness often presents itself, and as well as lifetime caps and parity and all those things. I think that the 988 legislation might be the most significant national mental health positive impacts is the creation of the passage of the Community Mental Health Act by President Kennedy, the last legislation was signed before he was killed in 1963. So I think that the potential here is tremendous. How the state rolls it out. One of the things you asked is like 911, and one of the things like 911 is that federal legislation allows for states to charge a surcharge on each telephone bill, not each telephone call, but each bill, whether that's mobile bill or a landline, in order to raise the funds to support 988 and it being answered locally within their state and to provide those crisis services. So, for instance, in New Hampshire, we charge 75 cents on each telephone bill, and that raises $14 million a year, which pays for our 911 system. So states would have, and I believe Utah was the first state that's already passed legislation to regarding 988, which includes charging a surcharge, in which they'll raise funds to help pay for 988.
I apologize, I hit all the wrong buttons. The question that popped in from April Jacobson, who proposed the 988 Act? She thinks that it is awesome.
It's been something that's been talked about for a number of years. I don't know that there was a single person that came up with the idea, but it's certainly something that that's been talked about through the National Suicide Prevention Lifeline Steering Committee for years. And there were a number of different organizations that have been involved in passage of that act, and they included, NAMI and NAFSP and Mental Health America, as well as local crisis centers, health providers. I mean, it was really a major effort in terms of people getting on board and getting behind it.
And one of the interesting things that you said there is it took a number of years. It shows that advocacy, one, is slow, but it works. It absolutely works, just not at the speed that we would like it to. And I think that a lot of advocates, especially those who are getting tired, burning out, or just starting, it's an important message to understand that we are making a huge difference. Things are happening, just not in our time frames, not on our timelines.
Such a great point about advocacy. Yes, I mean, having been involved over the decades in different advocacy efforts, if someone ever told me how long it was going to take when we were undertaking some of these things, I would have run in the other direction. But yeah, I mean, persistence really can pay off, and in this case, I think it really did. And I think, we talk about the gridlock in Washington and the divisiveness in Washington. This went through. I mean, there were a bunch of different votes over the past several years, and then it had to be reviewed by the Federal Communications Committee and other groups. But at one point, I think all but 2 members of Congress voted for it. So I think it's had tremendous bipartisan support. And someone recently said to me, mental health isn't a bipartisan issue. Advocacy, it's a non-partisan issue. There's no partisan issue.
Well, thank you both so much for being here, Ken, Elaine. The hour just flew by. I can't thank you both enough. We have about 30 seconds left, so you can each have 15 seconds for final words, Ken or Elaine, is there anything that you want to say before we jump on out of here?
Yeah, I'll just say NAMI Tennessee rocks, and so does the NAMI Tennessee Suicide Prevention Program, and 1-800-273-8255 is the National Suicide Prevention Hotline number.
Thank you, Ken, so much.
And I'm going to quote Ken by saying, we can all hold on to hope, and if you have someone who is hopeless, hold on to the hope for them until which time they can get back into holding on to hope themselves. So don't give up. Things are getting better, and we're almost on the other end of this pandemic, which is great too. So
very exciting. Thank you both. Thank you both so very much for being here. Listen, if you're not already a member of NAMI Tennessee's email list, it's absolutely free. All you have to do is go to, I'm going to get this right, namitn.org and sign up, and you find out about cool events like this one, which happens every Monday at 2 Central, 3 Eastern. We will see you next week. Thank you, everyone.
Bye.